Continuing education credits for physicians and other healthcare professionals are provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information. The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed in this podcast are solely of those of the hosts.
Welcome back to the Cribsiders. I'm Chris the Chimanchu. I'm joined again tonight with my co-host, Sam Mazer, and our new producer, Jess Reed. Say hi, guys.
Hey, Chris.
Hi.
Tonight, our guests are Dr. Colette Desrochers and Dr. Jennifer Mautone to discuss integrated behavioral health in primary care. But first, Sam, do you want to remind our listeners what the show is all about?
Chris, I would love to. So we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine.
So we have a fantastic conversation with two guests. Dr. Jennifer Mautone is Associate Professor in Psychiatry and Pediatrics at the Perelman School of Medicine at the University of Pennsylvania and Director of the Pediatric Research Consortium at the Children's Hospital of Philadelphia. Dr. Mautone was one of the founding co-directors of the Integrated Behavioral Health and Primary Care Program at CHOP, and she practices in a primary care center in West Philadelphia. Her work focuses on improving collaborative relationships between families, schools, and the health system, and increasing equitable access to and utilization of culturally responsive behavioral health services. We also have Dr. Colette Desrochers, who is a primary care pediatrician and clinician educator with 30 years of experience at the Children's Hospital of Philadelphia. Sharing her love of pediatric medicine while teaching medical students and pediatric residents in the primary care setting brings her great joy. She has enjoyed rich research partnerships with clinical psychologists exploring areas of ADHD, depression, and suicide prevention. She's delighted to have been invited to be a part of the Cribsiders podcast. We're excited to have Dr. Mautone and Dr. Desrochers, who are here with us today to teach us about current barriers to timely mental health services, innovative strategies to address these barriers, and opportunities for pediatricians to incorporate these strategies in their own practice.
I really do think our listeners are going to be psyched to hear this discussion.
Yeah,
I couldn't come up with anything better. Sorry.
Yeah, it's all good. It's all good.
All right. I have Dr. Colette Desrochers and Dr. Jen Mautone here. Thanks for coming on the show.
Glad to be here.
First, because we're sort of an informal group, is it okay if I call you both by your first names? So it would be Jen and Colette?
Sure.
Absolutely.
Excellent. So we do have sort of a big, large episode, lots to talk about today. But before we get to that, I sort of want to ask each of you to tell us a little bit about yourselves, what you do, and maybe something outside of medicine you like to do. So let's start with Colette.
So I'm a general academic pediatrician at Children's Hospital in Philadelphia, where I've been really privileged to practice for over 30 years, teach medical students and residents, and have been able to be involved in some clinical research with behavioral health and supporting families and connecting to care for trauma and grief, depression, and suicide. And that's grown over the course of my career. I'm really happy to share what I've learned.
Excellent. And we're really happy to have you here to be able to share your experience. Jen, what about you?
So I am a pediatric school psychologist. I've been at CHOP for just over 20 years now, and I practice in an integrated behavioral health and primary care clinic with Colette. And I'm primarily a researcher, so I think a lot about what we can do to improve access to and utilization of care when I'm in my work, part of my space. And outside of work, I hang out with my kids and our dog, and kind of have developed a bit of an obsession with solid core these days. So working on keeping those abs nice and strong.
That's good.
Nice. They say we don't advertise for them, so this is free advertisement. There we go.
That was not intentional.
Yeah. Well, if anyone from Solid Core is listening to this, feel free to sponsor us. All right.
Absolutely.
All right. As Chris just mentioned, we have a huge case. We have two guests as well. We want to hear each of your opinions and recommendations and advice. And so because of that, we're just going to jump right into it. And Jess, if you wouldn't mind just starting with our case from Castleac Children's. Hey, Cribsiders listeners, whether this is your first episode or you've been with us since day one, you know our goal has always been to share real wisdom about practicing medicine. So let's talk about something that actually changed my day-to-day as a hospitalist, and that's FIG scrubs. I can't walk into a clinic or hospital without seeing people in FIG scrubs, and I get it, I wear them too. They're incredibly soft, form-fitting, and durable, and it's not just dust. If you've been watching a certain popular ER drama on TV, yep, they're in FIGs too. These scrubs get it. That's what drew me in and what keeps me coming back. And because we work with kids and kids come with messes, I love that FIGs are antimicrobial. When stuff gets on your scrubs, and it will, you just wash them and they come out wrinkle-free. I've washed mine well over 50 times and they still look brand new. All of that and so much more is why we've teamed up with FIGs. Now, Cribsiders listeners can get 15% off. Just go to wearfigs.com and use code FIGSRX. That's WEARFIGS.com and use code FIGSRX for 15% off.
So we have a case from Cashlock Children's Primary Care Clinic. We have Ty Testy and B. Haver, who are two siblings presenting for wild child checks. Ty is 14, well known to the practice, and B is a newborn baby. During Ty's last well visit, he flagged for moderate depression on his PHQ-9 and was referred to outpatient therapy. Given long wait times and insurance issues, they have yet to connect with therapy. The sibling's mom, Ingrid, also expresses feeling overwhelmed with having a newborn baby and asks for additional support. Colette, this first question's for you. Difficulty connecting to mental and behavioral health services is a common topic of discussion during routine well visits. In addition to long wait times and challenges with insurance, what additional barriers have you heard from your patients and their families?
There are so many that people identify and share with us. Transportation, of course, is really basic. If practices are not located close to where someone lives, hours of operation can be a hindrance if the parents are working and managing their household, trying to find time to do appointments that match their own schedules. And then taking children out of school can also be a challenge. We're talking about kids who have risk and have difficulty, and missing school is cumulative and can contribute to worsening mood and mental health and achievement. So those are some of the things that are top of mind for me.
You know, and that's all the things on top of insurance and ability to actually find providers and wait times, which we'll get into as well. You know, those are the obvious ones, and you just brought up a couple more great ones. And maybe we'll shoot this one over to Jen and really talk about what is this integrated behavioral health and what are the types of integrated behavioral health models that exist?
Yeah, what are we talking about anyway?
Yeah,
so,
exactly.
What we're really trying to think about is this really fantastic opportunity to capitalize on the patient-centered medical home model and think about how we can meet kids and families where they are in an environment that's familiar, that's trusted, and that oftentimes feels completely different than what folks would imagine as a mental health clinic, right? So there's a variety of different models. Most of these things initially started in adult primary care spaces, is often the case from when we're thinking about pediatrics. But we can think about different levels of integration. So there could be a behavioral health provider who sits in the office but sort of exists somewhat separately, right? Uses a different kind of health record, may have completely different administrative structures, but is right there down the hall if you need them, right? Or to more fully integrated models where you might be able to have the behavioral health provider step right into the office visit in the moment, like this young person with the PHQ-9. The pediatrician's like, hey, I could use someone's eyes on this person right now. And so that's a more fully integrated kind of approach.
And maybe I'll follow this up with what these clinic visits physically look like. I guess it depends on how integrated it is, as you were just mentioning. Let's take a fully integrated, because it seems like the more integrated you can be, the better it is. What do those clinic visits look like as you were kind of mentioning about how the providers interact, how each of them come into the room, whether it's part of the same visit, whether it's billed as separate visits, whether it's, those types of things. What do the clinics generally look like?
So we think about fully integrated models. Well, first, actually, the level of integration can vary based on resources that a health system has available, right? And if we look at recent research, meta-analysis actually has suggested that level of integration doesn't matter necessarily in terms of kid outcomes, but the deciding factor may be more around what the goals are for the patient population, for the clinic, and for the resources that are available. So in some cases, you asked, like, are they billed as part of the same visit? Sometimes. Some health systems have that opportunity. Other health systems, the behavioral health providers have to operate or are operating more on a fee-for-service kind of way. And the health insurance, there's a behavioral health insurance, a physical health insurance. That creates a whole other different financial structure. And so those two visits end up existing separately in the health record for a variety of different kind of more administrative reasons, but operationally in a fully integrated clinic, the patient may not experience that as two different things, right? So for example, I would go in for this young person, say Colette was the teenager's pediatrician. She asked me to come in. She's finished her office visit in terms of the well visit for him. And then I go in and do my thing. From the patient experience side of things, it's all one seamless experience. What happens administratively on the back end is different, right? And that, again, is dictated by some of the insurance related pieces.
Now, one question I have are these appointments set up to be these two consecutive sort of visits together, or is it can also happen more spontaneously? Say Colette sees a patient, it wasn't known that the patient was going to have these issues. She identifies mood issues, does the PHQ-9 says, ooh, it'd be great if we really got you in to see, one of our behavioral health providers. And then she's like, oh, Jen's right here. Do you mind if she walks in and she can at least get introduced, maybe start some stuff and then set up for future appointments? Or does it always have to be like, all right, every time you come in, it's going to be like, just like we see other clinics where, whether it's in like oncology or rheumatology, like these sort of like you come in, you're expected to see this person, then this person, and this person every time. Like, how does that look like?
It can work differently in different models. Again, there are some models where you can schedule with both people and have a sequential visit, but most of the time it's a little bit more organic than that, where you're engaged in care, you identify a behavioral health need, you explore the family's readiness to engage in behavioral health, and then introduce your colleague, who is your trusted colleague, to come into the space where the patient exists. They're already comfortable. And that, I think, can help to promote engagement in care.
Gotcha. But so from like a scheduling standpoint, I mean, to have that sort of ability, Jen has to be like available, not in the middle of some other session, and to be able to walk over and be like, all right, I can see you. Or, obviously that also ties up more of your rooms. I don't know how much time you have for your rooms, but in my clinic, it's like, we got to turn over the room. We got to get those vaccines and get those labs and get the next patient in. So are those the types of things that you also see? And how do you get around some of those types of issues?
Every day you do the best that you can, right? So every day you do the best that you can. And I think that what we are doing most of the time is trying to put the patient that needs us most gets the most of what we have. If there's someone that really needs the care, they get the care that they need. It's not always possible. We're talking about ideal integration of care. So the integration of care model, there is also a psychologist that is seeing patients. So they are not generally free to always do that warm handoff. The warm handoff can improve successful completion of referral. So it's a bit of a dance. It's a bit of a balancing game.
And, here, obviously you have your model at CHOP and you have Jen, who's, amazing. You have a psychologist there. As other people may look at trying to build similar models, like who can that behavioral health provider be? Can it be a social worker who's trained in mental health? Does it have to be a psychologist? Like who else can that be who can sort of fill that role?
I think, we've seen some great examples from pediatric health systems all over the country using a whole variety of behavioral health disciplines. So psychologists, clinical social workers, licensed marriage and family therapists, other master's level trained clinicians. So I think that's one of the flexible parts of the model, right? And some of it is the challenge is that we're not all trained. Most of us are not actually trained to operate in a primary care environment. When I came up through my graduate training, I was fortunate to have primary care focused experience throughout. But many of the folks that we've hired in our program, or that I know, at peer institutions have hired other folks who are trained primarily as outpatient specialty behavioral health clinicians first. And then they start learning primary care later. And it's a whole different game when you end up in a primary care space, right? And, Colette was talking about how sometimes I'm not available. We operate a little bit less fully integrated. I think we are aspiring to be fully integrated, but we're a little bit closer to the co-located space in a lot of our clinics for a whole host of different reasons. So that we don't have protected time for those same day visits in most of our clinics. And it's obviously going to work more smoothly when the pediatricians know that the behavioral health clinician has that time protected, but then the behavioral health clinicians need to be trained to be ready to do that and to move between attending pediatricians at a moment's notice. If there may be residents in the clinic, that's a whole other level of things you want to consider. So all of these things kind of come to play when you're growing your program.
Thank you. And I just touch on what you were just mentioning, Jen, in terms of the different types of models and those names. So fully integrated versus coordinated versus co-located. I think I've heard some of those terms before, and I would love if you could kind of delineate kind of the differences between each of them.
Yeah, I think that's a great question. I think a lot of times, I joke with some of my colleagues is sometimes those of us who are fully immersed in this don't even know what we're talking about from one moment to the next, or we can't all agree on what we mean. When I refer to levels of integration, I'm referring back to the SAMHSA and HRSA Center for Integrated Health Solutions that we have here, available to us in the U.S. And they provide a whole lot of guidance in terms of what level of integration means and kind of what components you need available to qualify at, sort of each level. So when we think about sort of not integrated, there's minimal collaboration. These folks may even be sitting in separate spaces, but they may have some communication by phone or electronic health record like electronic messaging. They don't know a whole lot about the culture that's going on in each other's offices. Is maybe like a preferred provider referral opportunity. And again, that's helpful. I don't suggest that any one of these things is better than another. They serve different purposes and they all kind of work together to meet youth mental health need. The next level is you move kind of along the continuum toward more integration. We start thinking about more intentional and focused sort of almost scheduled communication. So we get a little bit closer to shared treatment planning. And then once we get into those folks are still operating in different facilities. Then we get into more on-site, co-located. We're in the same building. We may have different systems, but we try to collaborate and communicate as much as possible. It's a little bit more a more opportunity to run into each other in the hallway, right? And say, hey, oh, Jess, I saw this kid that you sent my way. Things are going really well, but you can't see my progress notes. I can't see yours. We're in separate health records. And then as you get into more closer to the fully integrated side, you've got the same health record. You're in the same space. There's much more face-to-face communication. We can actually start to say, oh, Jess, you sent me this patient, Ty, and we were talking about some symptoms of depression. I met him that day. Remember when we discussed X, Y, and Z? Here's where I think we need to get together about our treatment planning. And I noticed that you're scheduled to see him next Tuesday. Could you reiterate this piece? So now we're really very much on the same page in terms of treatment planning. And we can also, the patient experience of that is, oh, look, Jess and Jen are communicating the same messages to me about my care plan. And I have a team of folks here who are trying to help me address these symptoms. So that's where you get into that more fully integrated space.
And I think her question was also about whether name definitions associate that. So we're using the word co-located versus other ones. Is there anything that we should know about the name definitions regarding each of those?
Yeah, so I think, like I said, that last one I was talking about generally it gets called the fully integrated kind of approach. There are those are levels of integration that I just talked about. And then there are also different models of integration, which is a whole other different vocabulary space. There's a primary care behavioral health model. There's the collaborative care model that's been growing up mostly in psychiatry spaces. So the collaborative care model is designed to address kids who generally have identified mental health diagnoses. The primary care behavioral health model can be for kids who have identified mental health diagnoses, but also is a little bit more of a population health approach to behavioral health integration, and can include more on the prevention side of things too, and doesn't generally have as much psychiatry involvement.
Great. Thank you so much for clarifying that. I think that kind of leads into our next question, which is, and this is for you, Colette, what are some of the proven benefits of this primary care model, and things that we're specifically thinking about, or what are the ages and conditions that you feel like this works best for?
Really, when I think about my own experience, which I can speak the most to, the behavioral health integration is effective for everybody from birth all the way through adolescence, just using different partners along the path. So we are very fortunate to have social workers that help with supporting our youngest families who have behavioral health needs, postpartum depression, toddler behavior, toilet training, temper tantrums, with a lot of coaching about what to expect from a parent's perspective of their child's behavior and how to modify behavior in the home to encourage positive relationship and positive behavior management to decrease some of the stress that families might encounter. So for our youngest kids, we have some social work model with extra training about development and behavior intervention. And then we get to the school-age kids where we see a lot of ADHD and school failure or academic underachievement, again, starting with anxiety and some mild depression. And then to the adolescents where we have more severe, sometimes, mental health diagnoses. And the partnership that we have with our psychologists helps us to refine our history taking, understand the vocabulary, figure out what questions we should be asking. And you have somebody that you can just say, I'm worried about this. Can you help me figure out how to explore this diagnosis or this problem for the patient? The outcome of that is that we, as pediatricians, push ourselves to be more directly involved with managing behavior, mood disorder, emotional health, dysregulation, ADHD, because we know we've got a scaffold. So we have people that we know that we're comfortable with, we can be vulnerable with and say, I'm thinking this, I'm not sure. We have a partner that helps us to build our skill. And our patients feel that because they see if I have confidence in my partner, she gives me confidence in the work that I do. The patients feel our competence as well. So not just my confidence, but my competence. And they have also grown with us. Patients are more engaging in mental health care. They're more able to talk about behavioral health care. Families are sharing the trauma they're living through because we have learned how to ask about it in a non-judgmental, patient-centered, family-centered way because we've made it a priority. And when you have the resources, you can shift your focus to really meet people where they are in a way that makes my practice of pediatric medicine so much more fulfilling and rewarding. And my relationships, both with my colleagues and with my patients and their children, the children and their families, much more rewarding as well. It's just a deeper level of connection.
And that's fantastic. And that's what we're all striving to do, is do better by our patients and do better for ourselves, right?
Yeah.
This is just a great opportunity to do those. I was also curious about, especially when you have to prove it to different people and things like that, what other outcomes are you guys seeing with this? It seems like you should obviously have improvements in whether it be depression scores, whether it be suicidal ideation, whether it be anything along those lines. But I'm curious what other outcomes kind of are have been documented.
Yeah, I think if we think about, like you said, we're talking about the patient-centered outcomes, so the patient-level, patient-reported outcomes, we do see reductions in symptoms of presenting concern, anxiety, depression, disruptive behavior. We see improvements in kids' sleep, in kids' adherence to their medication. If it's a kid who has asthma, for example, and they may be having an associated anxiety issue around the asthma, or having a flare, whatever, we can help with improvements in that area too. But the other pieces that we see are generally maybe stuff that might not get measured as much in some studies, but reductions in stigma related to mental health. We see improvements in parent self-efficacy as parents and caregivers. We see improvements in engagement in pediatric care. So we, again, when you develop this more comprehensive connection with the clinic, I can kind of be supporting kid and family engagement in healthcare broadly. When Colette was talking about the program that we have to support our infant and toddler population, we're implementing the program called Healthy Steps, which is a national model. In that program, we see improved vaccination rates, improved attendance at infant and toddler well visits, in addition to child social emotional outcomes and family well-being.
Awesome. That makes so much sense, and it's great to see that. Hey, Cribsiders listeners. On episode 135, we sat down with Dr. Tristan Nichols and talked about how AI is already changing how we practice pediatric medicine, from expanding differentials on tough cases to generating discharge instructions that families can actually understand. One thing that really struck with me is the idea that AI shouldn't replace our clinical reasoning. It should sharpen it, and that's exactly why I've been using Claude. Claude is the AI for minds that don't stop at a good enough. It's the collaborator that actually understands your entire workflow and thinks with you. Whether you're debugging code at midnight or strategizing your next business move, Claude extends your thinking to tackle the problems that matter. What I love about Claude for Medicine is its deep research capability. It goes way beyond a basic web search. I'm talking comprehensive analysis with proper citations, pulling connections across dozens of sources that I would never spotted on my own. It's like having a research partner who never gets tired. Whether it's working through a tricky inpatient diagnosis, reviewing the latest management guidelines, or putting together a teaching topic for my residents, Claude helps me think deeper instead of just skimming the surface. So Cribsiders listeners, ready to tackle bigger problems? Get started with Claude today at claude.ai/Cribsiders. That's claude.ai/Cribsiders, and check out Claude Pro, which includes access to all the features mentioned in today's episode. claude.ai/Cribsiders.
So one question I have, and maybe Jen, you can help answer this as well. So I don't know who best to answer this, because I think you both can address this well, but maybe Jen could try to answer this first. At the top, when we started talking about, challenges in implementation and other challenges, is there anything else that you want to let us know that we haven't talked about yet? And also, I don't think we talked about some of the challenges, but we also didn't talk about how you guys, at least in your experience, try to get around those challenges.
Yeah, I love that question. So I started out when we launched our integrated behavioral health program here at CHOP. I was one of the founding co-directors of the program, and I remember I will never forget this conversation with one of my administrative partners. And she was like, "What do you mean we have to be thinking about all these additional things? We just plop a behavioral health provider in the office, and everything's it'll just go." And I was like, "Well." Let's, slow that roll and consider a couple of other factors, right? What we've seen is the partnership between the behavioral health team or the behavioral health provider and whoever they may be reporting to. Like in our case, our behavioral health providers are not hired by our primary care practices. They're hired by behavioral health or psychiatry department and then partnered into the primary care practice, which is also, that's part of the challenge, right? Depending on how you hire this person, they get integrated differently. If they're reporting directly to the practice level leadership, that's going to result in some different kinds of supports for the team. But if there's kind of matrix reporting that our larger health systems get involved in, that can get complicated. We thought a lot about practice readiness for change as a thing, right? Like, we know that talking to our pediatrician colleagues, they were all like, this sounds like a great idea. And I know that my patients and families could use more immediate behavioral health support. But like, it does result in some changes, right? We need to have people learning how to schedule behavioral health patients differently, or to think about what it means when my patients start calling the triage line and they have more, different kinds of questions that they're asking the nurse team that's answering the phone. And so we needed to think about broadly, readiness across all of these levels. It wasn't just that I was going to show up there someday and start seeing patients. There were like kind of all these different moving parts and people that were going to get sort of just impacted by my presence in the office.
Colette, do you have any comments on that before I ask another question? I don't want to cut you off by just throwing it to Jen.
No, nothing at all. I mean, not nothing, but nothing specific to add to her conversation.
Cool. So I'll ask my follow-up question, because I really do think we need to talk about finances. It's not, this is not often a financial podcast per se, but I think everyone would agree that if we just had tons of access and we could just pay for a bazillion therapists to be around, all of our patients would do better, and if we could get them to afford it, et cetera, et cetera, et cetera. So I think we should talk about the financial implications of the clinic, both the pros and the cons, right? Is when putting in a provider in this case, is it cost more money for the clinic? Is that a huge piece or component? Or actually, look, we're getting our patients with all these positive outcomes you mentioned, we can prove that we're actually making money, or at least, appropriately making money for the health system. Where have you guys found that balance to be?
I think there's again, it sort of depends on the health system's financial structures and levers that they have available. And some of that even is influenced at the state level, right? Like, so here in Pennsylvania, for example, we have behavioral health administered separately from physical health, and then that results in a variety of complications. I have friends and colleagues at other institutions that operate as accountable care organizations, and they have different levers available to them where they may be able to capitalize on value-based care opportunities where the presence of the behavioral health clinician is supporting the overall population health outcomes that are being measured. Whereas in our case, we're operating in a fee-for-service model, so my patient numbers and that volume is what's really important in terms of some of the financial sustainment. The other thing I think about a lot around this is that some states allow behavioral health providers to bill for preventive behavioral health service, and we currently can't. So I can't bill for an office visit with a kid unless I can render a psychiatric diagnosis associated with the visit. And in primary care, in a lot of places, but in primary care in particular, that's tremendously limiting, right? Is that, so many of the kids who have presenting concerns that their pediatrician recognizes I am in a position to help with, they can't get me involved because the kid's not meeting criteria for a psychiatric diagnosis at this time, and I can't get reimbursed for that service.
It's interesting because in California, I believe it's Nadine Birch who's done the work to say ACEs increase risk for psychiatric diagnoses, and she's pushed through the government to get reimbursement for risk for diagnoses. And that is just not happening, but needs to happen because we have the data that shows all of the ACEs that increase risk for mental health diagnoses. And we don't have the financial reimbursement to decrease risk. How do you measure the cost of a child not killing themselves? How do you measure the cost of a child having success in school rather than failure? How do you measure the improved productivity of a family that can stay at work? We don't measure those things. We know that those are the downstream effects. We don't measure that. So that's the part that can be incredibly frustrating when you're trying to advocate for something that you know is important to a child and family.
And that's really well said. I think, you know, obviously if you're a health system that has a lot of money that can funnel into this because you know this is good for your patients, that's one thing. But if you're trying to prove it, and you usually are based on government dollars, for example, it sounds very state dependent on saying, hey, can we get money? Can we bill on a diagnosis of preventative medicine versus can we bill on a diagnosis of you know, it's reactive medicine, if you will. So thank you for touching on that. Obviously, all our listeners, you guys all work at different health centers, all have different opportunities that you can or can't do. But it looks like check out your state and check out some of those pieces to see actually whether you can bill for some of these things ahead of time, and it might give you the great opportunity to start these clinics. With that in mind, I was thinking we jump to the next case. What do you guys think?
Sure.
Perfect. All right, Jess, take it away.
All right, so now it's time for baby B's visit, and you have the teen sibling step into another room while you review Ingrid's Edinburgh postpartum depression screen, or EPDS. You see that she scored 11, which suggests possible depression. This is a question for you, Colette. What resources specific to integrated behavioral health are available when postpartum depression is identified or families are having a hard time adjusting to a new baby in the home?
So, Jess, let me just add that we are so fortunate in our practice to have our Healthy Steps program, again, a national model of intervention for our youngest families of children from birth to age 3 or through age 3. So we have a social worker that will sit and meet with the family and talk to the parent about their own experience of postpartum mood disorder, and can schedule individual contact points with the mother to give some scaffolding and support for her postpartum depression. As pediatricians, we have also a teen parent program in our practice. So we bring the teen parent and their baby in for visits that are at the same time. The baby is seen for their visit, the teen mother is seen for their visit, and management of postpartum depression can be facilitated in that model as well, which it's been really rich and a great asset to add to the office that we have.
And maybe I'll throw this to Jen and ask, do you need to have a specific trained provider that's really comfortable seeing adults that you can pull into this? Or is this part of pediatric training to always be able to deal with something like postpartum depression?
Yeah, I think that's a great question. I think that, you know, a lot of the work that pediatric behavioral health providers do is with parents and caregivers, but not as the parent's therapist necessarily, right? So that's the part where I think it is important to think about scope of practice, licensing issues, and skills and training. So in our case, where Colette's describing our Healthy Steps clinicians, those folks are trained in early childhood development as well as perinatal mood and anxiety disorders and how to support caregivers. And so, you know, they do have kind of that range of training. So I think it's really important for the clinics to think about if this is a role that they want their integrated behavioral health clinicians to be taking on, they're thinking about hiring folks who can work within the scope of their practice competencies and to think about that. I mean, I think Healthy Steps is one model, and the Healthy Steps National Office offers a tremendous amount of training and support to the Healthy Steps specialists. There are other clinics that I'm aware of all over the country where they may not be implementing Healthy Steps per se, but they're doing a lot of similar activity around supporting caregivers in that perinatal period. And again, they have kind of infrastructure set up to make sure that the clinician is, again, practicing within scope of competence. The other pieces that we've had to think about and that other health systems have had to think about is if you're providing care to the caregiver and you're documenting it in the infant's health record, that becomes a whole other point of consideration, right? So what type of care is being provided in dyadic models? The dyad, the caregiver and the infant are sort of the patient, right? The identified patient. So that goes in the infant's health record, and that makes sense. If it's direct with the caregiver, that may be a different issue. And so sometimes when we're thinking about family medicine clinics may have different opportunities that a strictly pediatric health system doesn't, or other things. Like these are all the kinds of multifaceted considerations that go on when we start thinking about implementing these types of programs.
That's awesome. And it's clearly something that we have to think about. And that's why we're bringing up each of these possibilities and say, all right, how do we address it? And it seems like how you what therapists you choose to hire goes a lot into that, but the Healthy Steps program is a good international way to make that happen. Colette, sorry, you had something to say on that too.
Yeah, no, I think that what is really important for pediatricians and family practitioners to reinforce with the parent is that we are going to be seeing them birth 2 weeks, 1 month, 2 months, 4 months, in that time period when postpartum depression is most prevalent. So I ask about mood. We screen for it with the standardized Edinburgh, but I encourage the mother to say that we are going to be seeing you and you are so important to us as well as your baby. So please, if you are feeling any changes in your mood, you can talk about it with us here, because we can guide you to resources and support. We can provide you with some support. And I think help to praise the great work that every mother is doing, because just like each one of us, every mother wakes up wanting to do the best thing they can for their child that day. And for some, it's really, really much more difficult than for others. So reinforcing our connection, reinforcing their importance as well as their child's importance, goes to building that trust relationship that might help them to be more open in sharing the not so great days that they're having.
Yes, thank you. I think all the care that we're thinking about the family unit so holistically is great. And so in that sense, we'll move on to the last part of our case, which is now focusing back on our teenager, Ty. So now it's time for Ingrid and baby B to step out of the room, and while you do your confidential visit with our teenager, Ty. During the visit, Ty discloses ongoing depressive symptoms, including new passive suicidal ideation. So Colette, we'll start with you. How can integrated behavioral health help with more urgent clinical concerns, such as suicide?
I think this is one of the areas that when they're able to do so, having a clinician that has advanced training in assessing the severity of someone's symptoms is very, very important. And that triage ability, the ability to say, yeah, this one needs to go right to crisis, or I think this patient's going to be okay to get an appointment next week, or, helping us with that ladder of what level of care a teen needs. That's where the clinical psychology partnership can be really very helpful and help to, again, continue to educate the pediatrician. This is what I'm thinking, but please, can you double check me? Can you be here to help me assess this patient's level of crisis and level of intervention that they might need? And then as we do that more and more together, again, you strengthen your own ability to use your own resources to make that determination when they're not available.
And it sounds like that's one of those situations where you can pull in that clinician, hopefully, if they're co-located, and they can almost be the expert triage for you. This person needs to go to the emergency room, or this person we think we can safety plan.
That's right.
And do that in that moment.
Every state also has TIPS lines, right? So every state for Medicaid patients has a TIPS line where you can pick up the phone call and call for a psychiatrist and get advice about management and get advice about who needs crisis or not. Again, the 988 hotline is fantastic, and folks that don't have as many resources as we have can use that, even if it's a professional person reaching out to try to figure out, how do I get the help I need for this patient, and where can they find the help? We are in an incredibly resourced location, and we understand that. We also have great need, but there are more and more available resources for pediatricians to be able to manage mental health in their practices.
Somewhere between the first warm weekend and realizing short season is getting close, eating well stops feeling optional. But when you're working long days at the hospital like I am, finding time to cook healthy meals can be tough. That's why I've been loving Factor lately. Factor delivers fully prepared meals that are designed by dietitians and crafted by chefs, so you get something that's actually nutritious and tastes great without having to plan, grocery shop, or cook. Honestly, my favorite part is how fast it is. The meals are ready in about 2 minutes. On days when I get home late or have a quick break between things, it's incredibly convenient to just heat something up and have a real meal ready almost immediately. I also like that they offer high protein options. Those meals actually keep me full through a busy schedule, which is huge when your day doesn't allow time for multiple meals or snacks. products. And Factor uses quality ingredients like lean proteins, colorful vegetables, whole food ingredients, and healthy fats. And there's lots of variety too, with over 100 rotating weekly meals, including high protein options, calorie-smart meals, Mediterranean-style dishes, and even ready-to-eat salads. So Cribsiders listeners, if you're trying to eat healthier but don't have time to cook during the week, this is honestly one of the easiest ways to stay on track. I've been using Factor, and it's been a great option for keeping meals simple during busy weeks. So head to factormeals.com/Cribsiders50off and use code Cribsiders50off to get 50% off and free breakfast for a year. Only offer valid for new Factor customers with code and qualifying auto-renew subscription purchase. Make healthier eating easy with Factor.
All right. Next question I have is just sort of more generally speaking about, where we are in our space of behavioral health and our patients. What sort of implications do we have in terms of like cultural considerations, language barriers, and other current healthcare policies have on sort of the expansion of mental health and behavioral health access?
That is a really great question, Chris. I appreciate you asking that and helping us think through these really important issues. I mean, one of the angles that I take when we think about this is when we consider what behavioral health evidence-based practices are in terms of the strategies that we're using. We look at research studies across the board. Many times, the research studies include families who are white, families who come from higher education levels, and families who may have higher levels of socioeconomic resource. Those are the folks who are generally more likely to be recruited for participation in research for a whole host of different reasons. So then you think about someone like me, and the things that I've learned about what works in behavioral health are based on a portion of a population. And then we also have to think about when families present to our centers, to our clinics, what they may be experiencing from one given day to the next, right? So I think there's like multifaceted issue around what works for whom and under what conditions, right? That's a very real question that we ask in behavioral health research all the time. But then also, like in the moment in your clinic, when you're working with a family who is from a marginalized identity or who may be experiencing tremendous amounts of community-based stress or sociocultural stress, and that's part of their day-to-day, that's going to influence sort of the ability that they have or the readiness that they have to engage in the care. And when we think about if a family's coming to our clinic and they're concerned about having sufficient food to eat or whether they're in a housing instability situation, like me sitting down and being like, so here's how I want you to deal with that, 5-year-old's epic tantrums that they're having. Like, that's not the place where the family's necessarily going to be most ready to engage in the care and then implement parenting strategies that can be really hard and time intensive, right? So there's kind of this multifaceted work that we need to do to consider all the different needs of a family that we can be presenting the same way that a physician would be in terms of addressing physical health. Like you think about a variety of different factors that are, playing into the presenting concern.
Colette, do you have any thoughts on this?
Yeah, I think that we can't really begin to address behavioral health needs for our patients if we're not understanding the social needs of the family. Just like Jen said, if a child is hungry, if they're not able to sleep at night because of gunshots out their window, if they don't get to school on time because the bus didn't come, like all of those factors affect a child's wellness and a family's function. And if we are not giving people the space to share what is true for them, we're not going to be effective at implementing any other change. We really have to present ourselves with care, compassion, non-judgmental. We have to practice asking the harder questions so that we're comfortable hearing the answers and develop our own ability to understand resources. One of the warm-up questions that people like to think about, well, what's a great book I should read as a pediatrician? And to be honest, as a pediatrician, maybe 15, 20 years into my career in West Philadelphia, I started reading sociology. I started reading $2 a Day by Catherine Eden. It really helped me understand that sometimes the baby makes the relationship. This is from her book, rather than the relationship makes the baby. If the relationship makes the baby, that baby's life course is going to be different than if the baby makes the relationship. And that's sociology. That's not pediatric medicine that I learned in medical school or residency. It is pediatric medicine I try to share with my residents that I work with in the practice. So if we are not open to hearing about somebody's lived experience, we are not going to be effective at helping them change that.
And that's awesome. And I can't believe I have to slowly swivel to another question here because that I feel like we should end with something like that. But I do have a couple more questions. Exactly. I was thinking also about one of the access pieces that your primary care clinic can help them with. So when you bring it into primary care, how can that pass some of the barriers that might exist, whether it be language or other policies or things like that we can kind of bypass because we know the primary care office can handle it?
Now, that makes me sigh a little bit because can the primary care office handle it?
Good point. And at least what do we strive to handle? And I guess that's probably the better question.
So these days, to be quite honest with you, the primary care office is striving to handle it all. And just like I said for that mom, we're trying to do the best that we can every day. And we may not be recognized by the ivory tower or the big hospital system or the insurance company or the government or any of those other places that have more power, control, and influence over day-to-day life.
Well, thank you for trying. I really, as someone who doesn't work in primary care, and partially because as much as I love primary care, it is so challenging in all these aspects that you're mentioning. Thank you for trying, and thank you for striving to make this happen. I appreciate it. And to all the primary care doctors out there, I really, really appreciate it. So thank you.
I mean, I do want to say, so, as someone who also practices primary care, I think something like this, having an integrated behavioral health or just having other support, I've been very blessed because in my own clinic, I have a social worker who's with me. I have a dietitian. I have MAs and nurses and pharmacists who are right by my side all the time. And I think looking at this integrated behavioral health care model, we realize that primary care is a team sport. And I think that's why this works so well, is because we realize we don't have to do it alone. It's not just the pediatrician or the family doc or the med peds or the nurse practitioner who's doing this. If you're practicing in a place that understands that primary care is a team sport, then everyone benefits from this. It decreases burnout, improves care of our patients. And so I just want to make sure that we put this out there. I want this to be in a positive note.
Yeah, absolutely. And honestly, when Jess asked me to be part of this, she initially, I think, maybe said, "Can you do this?" And I said, "I can, but not without Jen." Because we are an integrated behavioral health team. And to just have a pediatrician's voice on an integrated behavioral health podcast did not make sense. So I was the person that said, "Please, can we have our psychologist with us too?" Because her perspective is just as valuable as mine. And we have a shared voice and a shared approach to our patients' wellness that really means the world to me.
And
Jen, you're going to say something.
Yeah, I'm like, I want to jump in too, because Chris, when you said primary care is a team sport, that comment really resonated with me too, as part of what drew me to this space as a behavioral health clinician, because so many times, especially outpatient behavioral health work is interprofessional in a whole lot of ways, but it's also, you're in your office, you see patient after patient, and it's a little bit more individual. And I love the team sport environment that we're in, and being able to be part of that, and to have it just feels like such a privilege to be able to be part of this longitudinal relationship with families. I've been in this clinic for long enough now that, Colette's known several of these families, or many of the families, for multiple generations, and I get to be, that's a privilege that I now have, to be part of that multi-generational care, and to see the kids grow and thrive. And it really just feels like such a ripe opportunity to actually see mental health truly be valued as part of health care, in a way that, isn't always the case. And, for many of us who kind of stay on this sort of strictly mental health or behavioral health outpatient practice side. So that's part of what I love about it. And I think some of the great opportunities that exist in this sort of integration space.
And adding on to that and thinking about growth within the area, I would love to hear from you, Jen. What do you think is the next frontier in integrated behavioral health? Where do you think there are opportunities to improve on existing programs, and either, kind of at CHOP or nationally?
Oh, I love that question, Jess. I think there are so many really cool opportunities, and my answer that I'm sharing now is completely aspirational and totally not tied to any financial mechanism. So don't ask Sam, because I don't know exactly how to pay for all of this. But I think that the integrated behavioral health, one of the benefits is that it helps us get to more kids and families. And, when we're thinking about the population health approach in the patient-centered medical home, right? Like, we reach more kids and families, and we improve access, we improve utilization. That's great. And if you think about it, still, like, I'm one person, and there are more folks like me doing this work, but we're still individuals, and there still is a behavioral health workforce shortage, at least here in the U.S., a substantial one. And so I think one of our potential really cool opportunities is to start thinking about task sharing kinds of approaches. I think from my perspective, what I see in a lot of the practices that I'm familiar with, both within our network and in other health systems, like nurses in primary care, are underutilized a lot of the time, and may be able to get involved in a little bit more of the, some of the office visit related tasks related to behavioral health. We've done a bunch of work, and other health systems have done work around sort of care managers. Some health systems call them disease managers, case managers, family navigators. There's like a million different names you could call these roles, but paraprofessional type of functions that can help reinforce things that kids and families learn in the context of an office visit with a provider, but then practice skills between sessions, again, to kind of clinician extender opportunities, so that we can increase the impact over larger numbers of kids and families with still recognizing the workforce limitations that we have.
And Colette, do you have any kind of thoughts on that too? Anything that you are also seeing from an expansion, or what's the next frontier, whether it be technology or other, other clinician extenders, like Jen was saying?
Right. I think that more and more people are using the virtual space, and virtual visits or telehealth visits or video visits for behavioral health follow-up and behavioral health care. I do think that breaks down some barriers for families. I do, though, think we need to be mindful of the digital divide, that we have still several families who do not have the ability to access care in a video-based format. And to say that that's the answer for everybody is naive, because those access issues continue. And then the artificial intelligence, like support persons, those scare me a little bit. And I think that that's been public about how sometimes those can draw people down a pretty isolating path. So I think we need to be careful about how we use some advanced technology in caring for patients when what they may need most is human connection and relationship, because we know how important positive relationships are in building resilience and in building coping strategies. So I don't want to say, let's use these advanced technologies at the expense of the positive relationship that happens.
Totally agree with all of that, Colette, and that, it's important to be thoughtful about how tech is utilized and to ensure that we're considering issues related to access, equity, and other pieces. I think that there are technological benefits, though, like you did say earlier, and I just want to kind of highlight one other opportunity that I know some folks, I think Texas is actually implementing a model like this that's been really helpful, in that the technology is used even more to support the providers than patients and families directly necessarily. So that is also another opportunity. I know we're thinking about listeners who are, coming from all over different areas, and you may not have access to someone like me who can show up in your office every day, but there are maybe opportunities to get a behavioral health consultant available, by video consult to pediatrician, video consult to train and support other folks that could operate in those sort of clinician extender roles. And I think that's another way that tech could end up getting involved and could be useful.
Similar to the psychiatric telephonic consult lines. Yeah.
Yep.
Well, I want to express again how wonderful it was to have both of you on the show today. I really love talking about what you guys are doing at CHOP, how it can apply to many other situations. Hopefully other people, our listeners, if they don't have something similar, maybe this will give them the idea to maybe implement something very similar in their shops. So thank you so much for being on the program. Before we go, I just want to ask each of you, can you give us a couple of your own, what you think should be the main take-home points for our listeners when they walk away from this discussion? What do you think they need to know or try to remember from this? And let's go with Colette first.
I would say practice asking the off-template questions. Practice getting to know your patient and family. Practice being uncomfortable, because practicing helps us to get better and being uncomfortable helps us to grow.
Jen?
That was awesome. Thanks, Colette. I think, some of the things I'd like folks to take home is that, these models are not one size fits all. Different clinics, different health systems are going to implement things differently for a whole host of reasons. But always keeping the sort of patient and family or population health end goal in the vision helps drive some of the decisions that you may make around trying to implement an integrated behavioral health program.
Well, thank you again both for talking to us today. I definitely learned a lot, and hopefully our listeners did too. So thank you.
This has been another episode of the Cribsiders.
It's for the kids!
Get show notes and sign up for our bi-weekly Knowledge Food Formula Feeds newsletter on our website at www.cribsiders.com.
We're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. Special thanks to our producer for this episode, Dr. Jess Reed, and our wonderful social media team, which is mostly Denise Cruz on X, Blue Sky, and Instagram. I've been Sam Mazer.
This has been Jess Reed.
And this has been Chris the Chi Manchu. Thank you, and good night. Hey, Jess, knock, knock.
Who's there?
Therapist.
Therapist who?
Therapist's place for mental health is in primary care.
That's a good one.
All right.